Yesterday, oops, not this. No, it won't. Um, there we go. There it is. Okay. Hopefully everybody can see this chart. I sent this to you yesterday. It's a handout, oops, that I use. Oh my goodness. Okay, I'm going to do it small just for a second. If you can see, these are the three main opioid receptors. There's mu, kappa, and sigma. Delta plays a little bit of a role, but whenever you agonize a mu receptor, you get these effects. This is how you use the chart. You get respiratory depression, supraspinal analgesia, euphoria, also physical dependence. Kappa, spinal analgesia, sedation, meiosis, which is myopic pupils. Sigma, you get dysphoria, hallucination, respiratory and vasomotor stimulation. So basically, if you go to the drug over here, it says morphine is an agonist at mu and kappa. So that means morphine is going to cause all of the effects of mu and kappa. There are good and bad effects of each of these opioids. And so you can see oxy, you don't need to know meperidine, that is Demerol, and fentanyl, butorphanol, buprenorphine. Okay, basically, those first, morphine, oxy, and hydromorphone is just like oxymorphone. Hydro came after oxy, so this is an old chart from my anesthesiologist, so it's a very old handout. Doesn't have hydro, but basically hydro does what oxy does. So it's telling you those pure agonists give you all of these effects. Now, when you get into butorphanol, it's an antagonist, so it blocks mu or does not cause those effects, but it agonizes kappa. Do you see under kappa it says sedation? Butorphanol is actually not too bad of a sedative when you mix it with other agents because it agonizes that receptor. And then when you get to buprenorphine, it's an agonist at mu, but it blocks kappa. So butorphanol and buprenorphine, because they're not full agonists, they are not as potent for pain. Let me make it big now that you've seen. Whoops, where did it go? So I don't know why it's small. Anyway, so some of the effects under here, which I'm going to talk about, is the cardiovascular. You can get some mild bradycardia, some hypotension, respiratory. It depresses the respiratory center, but it decreases responsiveness to CO2. When I've told you an animal's drive to breathe, the reason they breathe is typically in response to an elevated CO2. When animals are on especially pure agonists like morphine and fentanyl, the brain's responsiveness to that high CO2 is altered. It's not as responsive. So you see patients with higher CO2s, and we usually have to just ventilate them more. There is some gastrointestinal, which the emesis, mostly with the pure agonists. So you tend to see a little more vomiting when you use hydroxy or morphine. And then from central nervous, you get some mild sedation. You can get increased intracranial pressure, and you get some panting. Now, I don't have the second sheet to this. This was a long time ago. But there are the panting comes from them feeling like they're hot. Some cats will be febrile after anesthesia. So you guys will wake up some cats, and they might be like 103, 104. And sometimes that happens with buprenorphine. Usually the fever goes away, and it's usually an effect of the agent. We are not sure why, but we will have some cats that do wake. It's not the malignant hyperthermia. So I know we've talked about that. I didn't want you to think that came through. So you should have received that chart yesterday. You might want to print it or just take a screenshot of it. But right now I'm still talking about opioids in general. They cause bradycardia. They decrease rate and tidal volume, so they don't breathe as often and they don't breathe as deep. So to monitor, the concern is I just watch their rate and character. I mean, I've had patients with respiratory rates heavily sedated or under anesthesia at 6 breaths a minute, which is like on the low end of normal for an anesthetized patient. But as long as they're maintaining their oxygen and and we're taking care of CO2, I can live with a respiratory rate of 6. Okay. If you look at your animals at home sleeping, look at your pets, your dog, your cat. A lot of times, I mean, Bo was sleeping the other day and he was 4 to 6 breaths a minute. He was zonked. So when they're sleeping at home, that's about what they're going to breathe. So you just have to watch for, where it becomes too depressed. So you tend to get meiosis in dogs, but mydriasis in cats, horses, and ruminants. So the cats get that very saucer eye pupil. That's when I talked about doing PLRs. If you have a cat that's had a lot of opioids, their eye is always going to look a little more dilated than normal. You can see hyperthermia, increased responsiveness to noise, can get some decreased urine production, but as long as they're urinating at least 2 times a day, then it's usually not a problem. Some of the adverse effects in general, now, most of these effects are going to be more profound when you're using the pure agonists like the morphine and the fentanyl. You don't tend to see as much of these side effects with the buprenorphine and butorphanol. Because remember, the pure agonists are doing something at both receptors, not just one receptor. So you can get disorientation, dysphoria. Euphoria is you feel like you're in a great mood. You can get dysphoric patients where they howl out or they cry. And again, with horses, they're going to stay away from those pure agonists because they have the more receptors. They usually have more of the adverse effects. And you can get some pronounced bradycardia. A lower heart rate, now, you should not get a heart rate like an alpha 2 heart rate. When I say it'll just maybe be a little bit lower, not where I'm talking about like the 30s and the 40s. That's alpha 2 heart rates. It does, a lot of people that get nervous about opioids because of the respiratory system, you can get a decrease in rate and volume, oxygenation in the artery, CO2 in the artery. Now, I want to make a note, ceiling effect with some agents. What this means is that they'll reach a level of respiratory depression, and even if you give more than that, it doesn't get any worse. I don't know if I told you guys the story of when I was in the intensive care unit and it was like 1 a.m. and I gave this cat butorphanol. I was by myself, 20-some patients. And as soon as I pushed it, I went, that was a lot of butorphanol. And I went back to the chart and I gave the cat milligrams instead of mils. So that cat, and butorphanol is 10 mg per mil. So that cat got 10 times its dose. Now, thankfully, I knew as an anesthesia tech, I was just picking up shifts in the ICU for extra money, but I knew that butorphanol has a ceiling effect for respiratory depression. So even though I went over the cat's dose, I shouldn't get worse respiratory depression. So I monitored the cat for being overly sedate. It was not, it was responsive. Normal respiratory rate went a little bit lower, good gum color. Pupils weren't overly dilated. So what I did is I observed the cat because butorphanol is not 100% reversible. It's an agonist antagonist. So if I gave them a lot, I've never had to reverse butorphanol. I've never had to reverse butorphanol because it is not fully reversible because part of butorphanol is an antagonist. Now, so That wouldn't have been the case had I given this cat oxymorphone or hydro or fentanyl. If I had done that, I probably would have seen some more of these side effects, but I probably picked a really good drug to overdose this cat. Thankfully, wasn't on purpose. I watched that cat like a hawk. It was fine the next morning. You can get some salivation and vomiting, and a lot of times you go to knock these dogs out, and eventually you got to pay attention to the back end, because sometimes when they've had the opioids, we're sitting there putting in a catheter, and then I smell something, and then they defecate. Not always diarrhea, but they can get gassy because of the effect it kind of stimulates the GI tract. So we can get this salivation vomiting. Some people will pre-med with Serenia when they use opioids. And sometimes we'll give ACE. Remember, ACE is an antiemetic. So you can give maybe an ACE pre-med and you won't get the vomiting. But the problem is after you give, this is so strange. I used morphine when I was at Purdue. We used it like water. We used it almost, it was our standard pre-med. And for some reason, I would get the vomiting and the salivation pre-op. But what we worry about when patients get opioids for continued days is we worry about GI stasis. So now we've got the opposite problem. We worry stasis is standing still. So we can get this, we can get constipation. So we go from one side to the other. So we have to be cautious because, you know, in horses, if we slow down the GI tract, they could be predisposed to colic. And if we have a GI obstruction, like if we're worried about a foreign body and then you give them a lot of opioids and then everything slows down, we need to get things moving to see if the foreign body will move. So, and I don't know, and maybe you have heard of this. There was one Super Bowl commercial. I want to say it was not the last Super Bowl, but the one before. And it was called, it was for OIC, a drug to treat OIC in people, opioid-induced constipation. In people that are on long-term opioids after surgery, the constipation can be severe. So in people, there is a drug to take that will help treat the constipation if you're on heavy opioids. And in fact, people that abuse like heroin and drugs like that can actually need emergency surgery because they can get a blockage because they get so constipated. That should be enough to tell you not to do drugs. But I'm just letting you know, like in dogs, we're usually doing maybe 1, 2, 3 days of opioids at max. So it's something we look for. It's not something I'd say I'd see all the time. I will say, like, a lot of our, when I was in surgery, a lot of our dogs, you know, were on a fentanyl drip or a morphine drip during surgery. They got injections of morphine. Probably the number one phone call I got from clients after surgery was, my dog hasn't pooped yet. It was maybe day 2 or 3. Well, I said, your dog was fasted. We gave opioids. Maybe the dog didn't eat in the hospital, but when I get worried about constipation, I would say, is your dog outside trying to defecate and cannot? And are they vomiting and not eating? If it's a constipation that's like an emergency, the dog is actively straining, not producing, belly is uncomfortable, and they're nauseous. Sometimes these dogs, I would say, my barometer was 3 to 4 days. By day 4, there should be a bowel movement. If they came in for surgery on a Monday, by Thursday, Friday, we should see a bowel movement. And most often they would call and say, oh, he finally pooped. I'm like, put a little pumpkin in their food. Try to encourage them to eat. Maybe give them some canned food to moisten up, Metamucil, get things going. Part of that is of the NPO, but part of that is the opioids probably slowed things down. And I'm just telling you this because you're going to be the one that's getting a phone call from a client saying, my dog hasn't pooped. Well, how do we know it's constipation that they need to rush in versus try some stuff at home? And that's how I talk clients through it, just to make sure. Now, obviously, there is addiction. This is mostly to do with people. I haven't seen, you can get some dogs that maybe a day or two after they're home, they're maybe whiny, clingy, but obviously that usually wears off. So physical dependence is typically in people. You can get some facial swelling and hypotension. Morphine has a preservative, and if you give it IV too fast, you can really drop their blood pressure. So some drugs, some of these opioids can cause some vasodilation and hypotension. Now, if they're on antidepressants or human antidepressants, it can potentiate the effect. So we do need to know, the doctor needs to know what other drugs, if any, the animal is on. A lot of people are using trazodone pre-op, and I think we have trazodone at the school because we've had some dogs that are kind of kooky. When we had Duke, that big shepherd, he was on trazodone. When you have dogs like that, they need to be, you may need to reduce your dose. You may not need as much of your opioid. So the reason we give them, the number one reason we use opioids as part of our pre-anesthetic plan is for their analgesia. The 3 categories we use, you can give them by themselves, but they're better if we give them with some type of tranquilizer, like morphine and ACE, hydromidazolam. Most of the time, we are using them with something. Now, post-op, if you're going to use them after surgery, you usually give them by themselves. But pre-op, you want them sedated. The reason, first of all, you're giving it to pre-treat for analgesia, to pre-treat pain. The second reason you're doing that is, to give them an analgesic. I will talk about neuroleptal analgesia when we get into induction agents. Because really, neuroleptal analgesia, the true definition, is a very profound sedation and analgesic state. And that's typically when you combine an opioid and a tranquilizer. If you give a dog ACE morphine, you have given the dog a neuroleptal analgesic combo. I can give very high dose of oxymorphone and midazolam, and I can actually induce anesthesia as a neuroleptal analgesic combo. So neuroleptal analgesia just means you've given usually a tranquilizer and an opioid. But there is also a way to do that to induce anesthesia in critical patients. Okay. So for example, you would pick one from this column and you would pick one from this column. You'd pick an opioid and a tranquilizer. And this is a good slide 56 because it tells you the names of the drugs, okay? These are analgesic. These are the neurolepts. Neurolept, analgesic, neuroleptal analgesia, using them together. Again, you can use them as sedation or induction of general anesthesia, but they have to be very geriatric or very debilitated. One of my example patients, as I said, you got the 13-year-old Shih Tzu that comes in that's hanging by a thread that has like 4 teeth for a dental, and one of them's hanging. And the liver and kidney are like, and he's kind of debilitated. But if I've got a 2-year-old lab that we need to do radiographs and he maybe broke a toe, no. Or if I have a cat for a spay, no. But this induction protocol is very good if you have a very geriatric, critical patient, because opioids like plus midazolam are very safe for patients. They have very minimal side effects. And again, like I said, it depends on the dose you give. The level of sedation depends on the dosage that you give. I will say with these patients, you always have to be cautious because they are very sound sensitive to when they're especially on pure agonists like hydromorphone, oxymorphone, We used to sometimes during induction, like while we were putting in their catheter, we would put cotton in their ears. And I used to put a little piece of tape on their head that says cotton in ears so you don't forget to take out the cotton. But if we did that, just to kind of minimize the sound and hopefully, and sometimes if they were sleepy in my arms, I'd put my hand like over their eyeballs to make it dark. So while I restrain them, sometimes I do that. You want to do everything to keep them calm to enhance your sedation. Now, the antagonists that we have will reverse any kind of central nervous system problems, respiratory depression, if you want to wake them up because you sedated them. Naloxone is the drug I'm talking about, which is Narcan. Naloxone is Narcan. I'm not going to talk about naltrexone. Naloxone, if you give it IM, it may take about 5 minutes. It depends on if they're cold. It depends on how good your shot in the muscle is. Sometimes you give a crappy injection. But in general, if you get it in the muscle and they have a fairly normal temperature, it could be 5 minutes. If you're going to give it IV, you want to do it slowly, and it might take 1 to 2 minutes. And they're going to be reversed for about 30, 60 minutes. Now, let me give you an example. If you give morphine and ACE, and you reverse the morphine, you still have ACE sedation on board. I've only reversed one animal after surgery when I was at Purdue that had morphine. The doctor thought he was too respiratory depressed, too out of it. We started pushing the naloxone. The dog jumped off the table, started screaming and snapping. I had to basically like throw myself back on top of the dog, try to hold his mouth shut, and we had to re-knock him out because we just came out of surgery. So we just took away his analgesia. Maybe we made the respiratory depression better. We reversed that, but we also took away the analgesia. So now the dog's coming out of surgery just felt everything we did. So that was not a great plan. The dog ended up getting another dose of morphine after we knocked him out. So you have to be really careful. I very rarely use it. Most fire departments and police departments now, because of the opioid crisis in America, carry naloxone or Narcan. So they find people overdosed in a car, they give them naloxone to reverse them out of their overdose. So typically when we are reversing them, we are only reversing opioid agonists. Partial agonists and agonist antagonists don't typically cause enough side effects or issues to need to be reversed. Plus you don't get full reversal. So really, opioid antagonists are really for opioid agonists. You can get, like I said, sympathetic nervous stimulation, the excitement, especially if it's right after surgery. I'm going to give you a little tip. It says you can prevent this by using an agonist or antagonist. We had a little technique that was kind of cool. If we had a dog that was too deep on morphine or fentanyl or whatever, the anesthesiologist would take a mil of butorphanol and he would put it in 10 mils of saline. And what we would do is we would push it slowly to effect till the respiratory depression got better. The dog started breathing a little bit faster, a little bit deeper, then we'd stop giving the butorphanol. By using not a full antagonist, we didn't fully reverse the morphine. We just kind of helped the respiratory depression. So you can use an agonist-antagonist technique if you don't want to do the full reversal. It was pretty cool because, again, we just didn't do that. Sorry, I just saw some. Morphine can be reversed by naloxone. Any pure agonist on the list can be fully reversed with naloxone, or it can be partially reversed with butorphanol. We really, in emergencies and overdoses, is when we would use an antagonist. The other thing is, if you if you do a C-section, this is another tip. We generally try to not pre-op. We usually try to not give the mother very heavy pure agonists. Like we don't usually use morphine or hydro. We'll usually use something like butorphanol or buprenorphine, because anything going to the mother anesthetically during a C-section is going to go to the pups. And when the pups come out, they can be respiratory depressed. So I have used naloxone to stick under their tongue with a needle. We usually put a little needle under their tongue, and because you can't hit a vein in a neonate. When you first deliver, you're not hitting a vein. So the next thing is you open up their mouth and you take a little 25 gauge needle, a little 1 ml syringe, and we inject a little bit of naloxone under the tongue to see if we can get them to breathe. That's only really if you use heavy agonists during a C-section. But again, our usual protocol, pre-med the mother with buprenorphine or butorphanol. And then when the last pup comes out, I would give her a dose on the table of like hydromorphone. So then we'd hit her with something heavier. But my job as an anesthetist, and I'm usually the one anesthetize, I kind of want to be with the pups, but they're like, you anesthetize the mother. And I'm like, I want to play with the babies. But my goal is to keep the mother deep enough to handle surgery, but not to have too many agents on board that are respiratory depressing. Once the last pup comes out, I can turn her up. I can give her more potent drugs, because we usually don't put the puppies with the mother after surgery for about an hour and a half, 2 hours. So that dose that I gave her in surgery, you know, a little bit of that might transfer in the milk, but it shouldn't be enough to cause problems. So that's just our C-section protocol. So there is a pain handout that we do in anesthesia too that goes a little in depth about the drugs. But what I want you, let me go back to the slide. Slide 44 is important. It tells you what category these drugs are in. So you need to know slide 44. If I ask you which one is an agonist, it's morphine, hydro, oxy, and fentanyl. The partial agonists are going to be buprenorphine. Agonist, antagonist are butorphanol. And then the only antagonist we use is naloxone. The whole reason we give these is for analgesia, and I have it underlined right here. Okay, right there. Okay, are there any questions about the opioids? The rest of this handout is what we're going to do next. So past slide 61. Starting at slide 62 is what we're going to go over for the next section. So this test is only covering the pre-anesthetics. And let me get to, okay, so let me, if everyone can see this homework sheet. You were supposed to know this vocabulary, be familiar with this vocabulary. The drugs, let me bop over to the drugs for a second. Now, on this homework sheet, atropine and glycopyrrolate, sorry, I lost my chat screen. There we are. Atropine and glycopyrrolate are your anticholinergics. Why do I give them? I'm going to either prevent or treat bradycardia or excess salivation. Those are the two main reasons I use them for anesthesia. So right now, what you need to know, well, first of all, you need to know what kind of drug atropine and glyco are. They're an anticholinergic. Why am I using them for anesthesia? What I just told you. Now, why is one different from the other? One is dirt cheap. One is more expensive. One is a better drying agent. Glycopyrrolate is better. Now, this is all stuff that I said in the previous lectures. is glycopyrrolate also does not cross the placenta. So you're not going to get those effects during a C-section. But if there is an emergency, I'm reaching for atropine. And if I'm going to use it in a patient that I don't want to speed the heart rate up too much, glycopyrrolate is better. Remember G, geriatrics? Glycopyrrolate will give you a little boost in heart rate, but it doesn't like speed up the heart, because sometimes I just want the heart rate to come up a little bit. I love glycopyrrolate. It's like one of my favorite drugs because I got a little boost, but I didn't like take the heart off running. Now, when we talked about side effects or patients it's contraindicated in, anytime it's contraindicated, if you have an emergency, like the heart rate plummets, you have like a major vagal stimulation. If something like that happens, you have to give it. Like you're probably only giving one dose. You're not gonna, it's not like you're using this for days. So if you give it, I can kind of live with some of those side effects, okay? Acepromazine was a phenothiazine. So why do I use phenothiazine drugs? I want to sedate them, calm the patient, make them more handleable. It is the only phenothiazine drug that we talked about. Let me get back to the PowerPoint, sorry. Now, these slides are going to give you the best information, okay? There was tranquilizers and sedatives, which were either the phenothiazines, benzodiazepines, or the alpha-2 agonists. So when you see the list of drugs, you have to figure out where does my drug fit in that family. Now, acepromazine, basically for a sedation, and it gives me anesthetic sparing, used with opioids, no reversal, which is a very important, it can be given orally too because there's a tablet, can cause some hypotension. So on these slides, basically this is the best thing to study. Your drug chart is supposed to help reinforce the information about these drugs. But where I'm going to get the majority of my information from the test is going to be the PowerPoint. So, I've really, during the lectures, I've hit on very key kind of, oops, watch this with this drug, like hypotension. Overexcitement. So sometimes you get, and the fact that it's not analgesic. And I don't know how many times I've warned you that they can act out if you do something painful because there's no analgesia. It's going to be better if you give ACE and blah, blah, blah. ACE and, when you use ACE by itself, then we're going to have an issue. Some antiemetic prevents histamine release. The key penile prolapse. So that's an issue if we're talking about mostly stallions. That's not, the penis in a male dog doesn't retract as far as a stallion. So that's why it's, really important in horses. We talked about the dogs that have sensitivities. And then if you have an overdose, you treat the symptoms because it has no reversal. So if they're over sedate, you watch mentation. If they're hypotensive, you check their blood pressure and give them fluids. You monitor respirations, make sure they don't become too respiratory depressed. Support them by putting them on bedding. They might not be able to go out and use the bathroom, make sure they don't soil themselves. It's like basic nursing care. If my patient has this, what can I do because the drug is not going away? And then there is a max dose. Now remember, benzodiazepines, we use them for their tranquilizing or sedating effects. If you put something on the test about benzodiazepines being anticonvulsant, I am marking that question wrong because I've now told you twice that is not why we use it in anesthesia. We use it for a sedative and we use it for a tranquilizer. So if someone puts that, what does that make me think? Either you didn't listen to my lecture or you're not paying attention. So I'm telling you now, as a freebie, do not tell me a benzodiazepine is an anticonvulsant. Yes, you can use them for seizures. That's not why I give them as a premed. And I told you what patients these are better for. They're short active, they're safe. Diazepam and midazolam are the two. So benzodiazepines are sedative and they're calming. Only in ill patients. Now, I have said in lecture, if you have an animal that has seizures, is a seizure patient, or they have a history of seizures, you might want to use this in the premed. That doesn't mean they're having an active seizure. That means I'm still using it to sedate or calm them, but this might give some extra protection if for some reason they were to have a seizure. If they have a seizure on recovery, they can't seize when they're anesthetized. If you have a dog adequately anesthetized, they cannot have a seizure. They can have a seizure if they're too light, or they can have a seizure when they're waking up from anesthesia. But if you have them adequately anesthetized, they're not going to seize. Okay? So, good relaxation. It potentiates my other drugs. It makes them stronger. And it gives me some appetite stimulation. It's a nice little side effect. But the thing that I really stressed is that when you use them in young animals, especially cats, but even sometimes dogs, you get more dysphoria and excitement. They're going to act out the opposite way. So it's really better. I like using diazepam and midazolam when we have trauma patients, when we have, if I have an unknown history, some cardiovascular disease, critical patients that don't need a lot of sedation, a midazolam or a diazepam would be better. But if you've got your everyday healthy, crazy patient, it's not going to be as effective. Kayla, I just saw your question. Do you not use it in gerbils? I would have to ask Neemer that question, to be honest. I have no idea. I've never anesthetized a gerbil, and I hope to never anesthetize a gerbil. Do you know why? Wait, Kayla, which drug are you talking about? Are you talking about, ACE? Can make their seizures. Oh, well, ACE promazine, let me back up. ACE promazine reduces the seizure threshold. So if you have an animal with a history of seizures, I would not pre-med them with ACE because it can bring out a seizure for ACE promazine. Oh yeah, I had no idea that gerbils were prone to seizures. I just learned something today. So you can still teach an old dog new tricks. Then probably not. I might shoot Neemer a little message about that and just ask her for the heck of it. But I would say if anything is prone to seizures, history of seizures, I try to stay away from ACE promazine and either use a benzodiazepine or an alpha-2. A benzodiazepine, the problem is if you have a 3-year-old lab that has seizures and he's crazy and you pre-med him with midazolam, it's not going to work as well. I'd probably use an alpha-2 because an alpha-2 is going to be more profound and it doesn't predispose them to seizures. Yeah, and maybe she said that. So I literally just learned something today. How cool. ACE and gerbils. Okay. So the benzodiazepines, everything I just said about benzodiazepines is very general. What is the difference? Diazepam has to go IV. It has to go IV to work. Midazolam is, everyone's a student for life. That's a tip. Always be willing to learn something. I'm the first one to admit I don't know everything. I think sometimes people think I sound super smart, but I'm like, well, there's stuff I definitely don't know, trust me. I've only done this 5 million times, but other stuff I'm like, cool beans, don't use ACE and gerbils. So the key thing between diazepam and midazolam, we use them a lot for the same reasons, except route is important. If you want to go IV, you can use diazepam. Now you can give, I think some people gets this confused. You can give midazolam IV. It's water-based. But the nice thing with midazolam is you can give it in the muscle. Remember, midazolam muscle, IM. It is more expensive. That's kind of the downside, but you have more flexibility with the drug. So expense and route are the two primary differences between the two. But again, they have pretty much the exact same effects. We give them for the exact same reasons. The only difference is route and cost. And also that, and diazepam is often combined with ketamine. Ketamine is the one drug, just a little FYI, you can mix with diazepam and it won't cause that little snow globe precipitate. But you do have to give it slow. You have to be cautious about that. Water soluble, good for exotics. And actually, Nemur, I did learn something when I talked to her in the office. They use intranasal midazolam in exotics. So you can give it intranasally and it is absorbed and will sedate them. So I know I talked about IM, IV, sub-Q, but in exotics, midazolam works really good. So if you're going to go into exotics, you're probably going to use a lot more midazolam. But I was like, intranasal midazolam, that's pretty cool. Like when I was at Purdue, there was a girl that loved exotics, and we would see some exotics for surgery. She always did the anesthesia, and I was like, have a blast. If I never have to anesthetize an exotic, I will die a happy woman. So more power to you. I helped some, but I was not the lead, and that was okay. It's not my specialty. So nice thing there. And the only thing, and I didn't want to confuse you guys, was when I talked about zolazepam, and you really didn't have to write up much about this because it is part of Tilazol, and I'm going to talk about Tilazol next week, or the end of this week. It's only Tuesday, yeah. So when we get into the induction agents, I'll talk about Tilazol. Zolazepam is the benzodiazepine component. Tyletamine is the dissociative component. So Tilazol is literally like ketamine Valium, except you give it in the muscle. That's why people like it. It's good for aggressive patients. And then flumazenil, there is a reversal agent. I've literally never had to give it. I don't even know if we have it at VCA. Maybe we do. But if there was an overdose, toxicity, allergic reaction kind of situation, but most clinics aren't going to have it. Hang on one second. Hang on. Okay, sorry. Real quick. The alpha 2s, the main reason of what I've tried to do on these slides is underline the main purpose for this drug. So alpha 2s you reach for when you need to sedate somebody. They do have analgesia. That's not the primary reason you give them. It's just a nice little bonus. They are not controlled. They can be used in an induction protocol. I mean, I'm really talking about them as a pre-med for sedation. They are better when they are mixed with something. You don't want to use them by themselves. The only two that you needed to know were xylazine and dexdomitor. I'll talk about these when we do large animal. And basically, you get sedation, analgesia. A big side effect is you get bradycardia. They are very profound, and I want you to know, you have to know the reason they are bradycardic is because they cause an initial vasoconstriction and hypertension when you give them. The periphery, they will look pale on these drugs because their gums all the capillaries vasoconstrict. When all that blood gets sent to the heart, the reflex is to slow down. It's called a reflex bradycardia due to hypertension. Now, later when that wears off, usually the heart rate does come up, but they can drop their blood pressure, so we just keep an eye on it. But if the heart rate drops, it's these drugs, and that's why it drops. These are all general effects. You can get vomiting. About 90% of cats will puke on this. 50% of dogs, but it's a reliable emetic in cats. It's what we use if they come in for ingestion of things. The bradycardia, it says hypotension here, but initially they're hypertensive. And then you do get some respiratory depression. The higher the dose, the more drugs you give with it. But again, it's usually manageable. You just watch their oxygenation, their pulse ox. Sometimes your pulse ox, I forgot to mention this, when you guys are in radiology, you won't have an ECG in there. You'll have your stethoscope. You'll monitor with your hands and your eyes and your ears. But sometimes I think she's got a little pulse oximeter, it's like a portable one, and you'll put it on the tongue. Sometimes it doesn't work the greatest because they're vasoconstricted. So when you put it on the tongue, there's not as much blood flow, and sometimes you'll get these low SpO2s. So, usually, same thing I said for SpO2, move it to other locations, see if it improves. It can get absorbed through our skin, but the main thing I want you to know, it's better for our everyday average middle of the road healthy patient. The geriatrics, the pediatrics, or very ill, the alpha 2s are not a great category because they have the most profound side effects. So probably, like I said, that decrepit Shih Tzu coming in for a dental with like 4 teeth, I'm probably not going to grab an alpha 2. And especially if he's just like chilling and the dog's not fighting me, I just need to give him a little sedation. I don't need to knock him on his butt. But again, the bouncy lab, the aggressive patients that I don't want a WrestleMania, then I'm going to give them an alpha 2. And they can react to noises. Xylazine is the cheap one, which is Rompin. 2 concentrations in this drug. If you're in charge of ordering at your practice, you always have to make sure they send you the right one. Small animal, we order the 20 mg per mil. But I've worked at a few practices that carry large animal concentrations, because like if you have a Mastiff or you have a big old German Shepherd, I've used large animal concentration drugs because I can give a smaller amount. So there are some practices that will carry like large animal Baytril. For example, Baytril comes in 2 concentrations. You can use large animal Baytril. It's the same Baytril, it's just the concentration is larger. So you just have to be very careful when you have drugs that have large animal and small animal concentrations. We always kept our large animal Baytril in a separate cabinet and our large animal xylazine, because that way someone was less likely to grab it if they're right next to each other. Or I would color the label on one. I made it like highlighter pink. So it should be like, why is that bottle pink? It's like, hello, this is a higher concentration. So you can certainly label them, do whatever you want so that you don't give the wrong drug. Just want to make sure you don't do that. Now, dexmedetomidine is more expensive. Think more letters, more expensive. But that's more dogs. Dexdomitor dogs. Just came up with that. Dexdomitor dogs. I don't know. It is more potent and safer. It still has all the side effects. You can definitely get into some major side effects with dexdomitor, but it's more receptor specific. It binds better, so you have a better chance of having less of these side effects. And then again, your sedation is going to be dose dependent. Lower dose, higher dose, depending on your patient's temperament, breed, procedure, what you need to do. If I have a dog that I need to take, sometimes when we would do orthopedic radiographs and we would do them all the time at Purdue, my boss wanted like 10 different x-rays. He's like, x-ray the elbows and the carpus and the stifles and get me the hips and do a flex view. And I'm like looking at him like, oh my God, I'm going to be in radiology for like half an hour. I'm going to sedate this dog on his butt because I have to take several radiographs. Sometimes we need to take one x-ray or two x-rays or clip some toenails, and I'll give a low dose because I'm like, well, I need him I need him sedated, but I don't need him like completely out of it. So do you see what it kind of really depends on my patient and also what I'm doing. Now remember, they have their specific reversal. Yeah, and Caleb, sometimes you'll have some cats, depending on what they do, that they will be sedated, even though the primary side effects are usually worse in that first hour. Some of the sedation can last several hours. And it could have been Caleb, she was a little bit cooler. Like if she was a little bit cold during it, it's going to take longer to metabolize. They probably, I almost would, well, Caleb, I'm gonna stab at something here. If they gave her just dexdomitor by itself and they gave her the bottle dose, that's probably why she was more sedated. I don't know if they gave her dexdomitor like and butorphanol or and something, because if they gave her, this is what I warned you guys about, when people use dexdomitor by itself, because really, if they just have to give her shots and a nail trim, that's not painful. Does she need an analgesic? Probably not. But yeah, and I'm sure Caleb, in this situation, maybe they didn't want to give her butorphanol or buprenorphine, but they were like, we want to knock her on her butt because she is the devil. But if they use the bottle dose, if they looked at the bottle and said, she's a 10-pound cat, give her this much, that's a pretty high dose. She is going to sleep longer. That's why I don't like to use, most of my doctors, we never use the bottle dose. But when you're using a drug by itself, you're always going to give a higher amount. You're going to see longer sedation, longer side effects. I'm going to guess that's probably why. So I went over the opioids. Let me peek at this homework. Remember, most of these first questions, go over the first part, is how do you classify anesthetic agents? Well, if you go back here, and I know that maybe that question sounded confusing, but we classify them by route and then time of administration. And then what is their effect? Is it an analgesic? Is it a tranquilizer? Does it have a reversal agent? And why would you need to either know the duration of action of the agent or how it's eliminated from circulation? Well, basically, when you are the one monitoring the patient and you are the one, you need to know how long do you expect to see those side effects? How long do you expect to have to monitor respiratory rate? Okay, so how it's eliminated, it's because if it goes through the liver or the kidneys and we're doing pre-workup and the animal has an issue with the liver or kidneys, then we don't want to choose that drug. So knowing how they're eliminated helps me choose which one is most appropriate for my patient. Also to potentially explain any side. I mean, if you are the person discharging Caleb's cat, like Caleb comes in to pick up his cat, and Caleb's cat's like rock to the world, we have to explain to Caleb, what should you watch for? Like I would have told Caleb, I would keep this cat separate from other cats. I would keep her in a confined space. I would feed her slow, but don't let her hang out by a water bowl where she would fall asleep and drown herself. I mean, it's very rare, but I had found a cat laying half in its water bowl that was sedated. Could it have potentially fallen asleep in the water bowl and aspirated or drowned? Sounds rare. But you know, you are the one that's going to be talking to clients like Caleb saying, we gave your cat this, and this is what you need to watch for. I'm like, don't let him hang out by the stairs. Don't let little kids, if there's little kids in your house, play with the cat. Keep them very quiet. Make sure they urinate and defecate. Okay. But you also have to give Caleb an idea. How long should he expect his cat to be like this? So we don't let anything go. Yeah, see, that drives me nuts, Caleb. Someone should have like talked to you about all this, like, you know, and if she threw up, that could be a late effect from the vomiting that sometimes happens with that drug. But yeah, I mean, what you guys, I think a good technician really takes care of their clients. And I don't want my client at like 11 o'clock at night going, oh my God, why is my animal doing this? So I try very hard to give them everything that could happen. This is a concern. This is not a concern. Okay. I try to go through that so that they're not worried at night. They know what to expect and they know when to call or they know when to go to the ER. Like if you see this, you need to go. This is normal. This is not normal. The more you understand about these drugs, the better you can educate your clients or your staff or monitor your patients. Does anyone, since I know we're 11:04, did anybody have any questions about these first general question 3? Okay. Should you administer an agonist-antagonist at the same time? You should not, because the antagonist is going to compete for the receptor. So normally, this kind of pertains mostly when you're using opioids, because sometimes you're going to use morphine. You probably want to stick with morphine or hydro because they're both pure agonists. So you can use morphine and you can use hydro in a patient, but if you give butorphanol after the animals had morphine, you can see some reversal. So generally, we are going to try to stick in the same category so you don't get competition. Now, alpha-2 agonists are all agonists. The only time you use an antagonist is when you want to wake them up. But opioids have drugs that are agonist, partials, ag, and tag, and those are, sometimes people will use those drugs interchangeably. Does that answer your question, Katie? Right. Right. So I never give them I would never give a dog morphine and butorphanol at the same time. And the only time I talked about using butorphanol, you can get the partial reversal. But like when you use xylazine and when you use yohimbine to reverse xylazine or antecedent to reverse dexdomitor, it's usually you're at the end of the procedure and you want to wake them up. Can we talk about 6 again? Oh, okay. Diazepam. So diazepam is the only drug. Most of the other drugs are like when I pre-med a cat, a dog, I usually mix the ACE. After you check your doses, you can mix them in the same syringe and give them as one shot. But if you're using diazepam, which is Valium, it has a propylene glycol base. It is not water soluble. So the problem is when you mix it with like morphine or hydro, you're going to see like this flaky, almost snowflakey Christmas globe or snow globe kind of thing if you shake it. But for some reason, it does not do that with ketamine. So you can mix ketamine and diazepam. But that is the only thing you can mix it. So diazepam cannot be mixed with other drugs. If you're going to give diazepam and another drug, you have to give them as 2 separate injections. And if you're going IV, don't forget this, because I see people that give one drug in the IV and they give the next drug. It can precipitate in the catheter and you can't see it. You would have to give diazepam, flush with saline, and then follow it up with your other drug. Does that answer your question, Joycelyn? Okay. And basically number 5, I've told you that Now, if you sedate them, they can still feel something. And even if you like, if you give them ace morphine, morphine is an analgesic. It's going to help the pain. It may not completely make the pain go away. Like if you guys are taking radiographs of these dogs and a dog has a cruciate and you go to stretch that leg, even if they have like ace and morphine on board, sometimes the pain is enough, they can still react. The big thing that you guys need to know, an animal can look really asleep and fool you. I've seen them fall off a table. I've seen them snap. I've seen them bite. When 1 second they were asleep, the next minute they react. I always have a hand on my patient. I could have a hand on their neck and I could be turned talking to you, but I have my hand on them and I can feel them move and I can tighten down if they start to move. So I just don't want you to get lulled into a false sense of security, especially because when you guys take x-rays of these patients, that room is loud. Every time you guys clink that tray, I've seen dogs asleep on the table, no one holding them, and people throwing those x-ray films in the tray that's metal. And then the dog goes and jumps. Be quiet. Somebody always hold them, because again, try to do things quietly, because like I said, I wouldn't want them to rear up and hit you. And like I've been clocked under my jaw, I don't know how many times. But I always try to at least have them where I can control them. So that's mainly what I wanted to do there. And then number 9, remember our preferred route is IM. When you give premed, you want to go IM, intramuscular. Remember, sub-Q takes the longest but lasts the longest. IM is a little faster than sub-Q. It doesn't quite last as it's kind of like in the middle. And IV kicks in the fastest, but it's associated with the most side effects because you're going directly in the bloodstream. When you use IV anything, morphine, hydro, dexdomitor, midazolam, you are going to see potentially more of the effects. And remember, when I talked about dosing mg per kg, the sub-Q dosing is always going to be higher than the IV dosing, and IM is going to be somewhere in the middle. It's kind of like the porridge is too hot, it's too cold, it's just right, the 3 bears. So my IM is the middle just right. Sub-Q takes too long, in my opinion. It does last longer, but it takes too long. IV kicks in really fast, but it doesn't last as long and I get more side effects. So IM is kind of my happy medium. So that's how I want you to understand that, is how does route, and then obviously I talked about oral route, I talked about sublingual, but the 3 primary average routes for surgery are sub-Q, IV, IM. Almost nobody does sub-Q. Most people usually do IV or IM. I got called in to do a C-section. I don't even know if I told you guys this. I'm helping out with some anesthesia on call for VCA. Not a C-section, a foreign body. And of course the doctor wanted to do the IV midazolam and hydro. The dog was super chill pre-op. Belly was a little uncomfortable. We ended up taking out a peach pit or some kind of fruit pit, and then it was surrounded in hair. First we thought it was a hairball, and I was like, this is a Chihuahua puggly looking thing. Of course it breathed like crap because it had a huge barrel chest and a big belly. So I battled ventilation the whole surgery, but pressure was good. But yeah, that dog, right after we gave the IV midazolam hydro, was pretty much like falling asleep in our arms. We had to like hold its head up. And it was a lower dose because he was already chill and we were going IV. So just keep that in mind for the routes. What other questions does anyone have? I know some people have popped off, but I can still stay and answer questions if people have more questions. I really want you to study the information about the drugs on the PowerPoint. And as far as the opioids right now, all I want you to know is the pure agonists are stronger for pain, have a little more of the side effects. Yes, Ashlyn, I got your email. And Yes, we can. I can hang out a second. Okay. Does anyone have any other questions? Michaela, you have a good, you have a good day. If you think of a question, I will send out this video for you to review here in just a bit. Yes, Sam, you can.